So this is about calcification, CHIP part 1. There is a microphone with Dr. Brilakis. If anybody wants to speak and wants to interrupt and wants to talk, please feel free. This is for an interactive session about calcium. And Jason will present our first speaker.
So first up we have Dr. Rob Riley, good friend of ours from Seattle, and he's going to be speaking today on the new kid on the block. And it's not about boy bands of the 1980s.
I have to tell you, I did Google that just because it took me back. They are old. That will make you feel real bad about yourself. All right.
Us mid-career guys are very familiar with
mid-career guys really get it. I don't know if I'm that.
I am mid-career.
You are not mid-career.
I'm not mid-career, but I'm not familiar with it. Why is that?
I don't know what's happening. Are we going to do the talk? So again, Robert Riley, Seattle area. Thank you all so much for having me. We're going to spend just a few minutes talking about the utilization of intravascular lithotripsy for severely calcified coronary lesions. These are my disclosures. So there's been this renewed interest in the treatment of coronary calcified lesions. And that's because we're seeing an increased prevalence because of both a combination of increased risk factors, chronic renal insufficiency, diabetes, et cetera, and we're simply doing things to people that we weren't doing 10 to 15 years ago that are associated with calcified lesions. So perivalvular treatment of coronary atherosclerotic lesions, high-risk PCI, et cetera. So we're simply doing things that we weren't. So we're going to continue to see this prevalence increase. And so it's gone from now we're sort of treating these severely calcified lesions in niche high-end centers to all of us in all of our cath labs. So it's something we all have to get up to speed with. The reason that it's important is that we see an increased risk for periprocedural major adverse events, and that's both in the short and the long term, whether it's acute coronary syndromes as seen in this pooled analysis or chronic coronary syndromes as seen in this pooled analysis. The reason for the increased risk in major adverse events is a decrease in vascular compliance. We see as calcified lesions come up, the vascular compliance goes down. That makes sense, right? We have these lead pipes for arteries instead of the normal vascular compliance. That decrease in vascular compliance leads to things we have to do to the arteries before we can get stents in, right? Whether it's specialty balloons, atherectomy, et cetera. Once the stent gets there, it can be deformed, right? Leading edge, we see it all the time, longitudinal stent deformation. Or if we do get the stent there, we see under expansion, again, because of this decrease in vascular compliance. And we know that MSAs are associated with poor long-term outcomes. We do have solutions for this, so various forms of atherectomy, some of which have been around for a long time. We also have specialty balloons, right, to try and cut, do these various modifications of the calcium. And yet, despite having these, right, they don't really get to the source of the problem, which is decreased vascular compliance. So the balloons have a problem, right, in that they're going to expand in the area of least resistance, which is typically the non-calcified segment, which is why we see problems with perforations, dissections, et cetera, and the same thing with atherectomy, loss of side branches, et cetera. So we really have imperfect solutions. This is a classic case, right? I'm doing the right thing, we get the burr in, I'm doing the work, right? And despite that, we have an NC balloon inflated at nominal pressure that looks like a big dog bone because, again, we have done nothing to the vascular compliance. We've just drilled a hole. So in comes intravascular lithotripsy. Balloon goes in, low pressure, right? So we avoid many of the mechanical complications that we often see with our other balloons trying to go to high pressure, et cetera. It then generates via sparks, these ultrasound waves that selectively interact with calcified lesions and do not interact with soft tissue. It interacts with the calcified lesions up to 50 atmosphere. And there's 4 different mechanisms by which these ultrasound waves create fractures in the calcium. And it's important, these 4 different mechanisms, because it creates fracture lines in multiple different planes. Those multiple different planes of fracture lines are important in really changing compliance. And there's a great mechanism of action paper by Dean Kariakis, et cetera, and Jack up there on the top right that you can take a look at later. This is, again, just a little bit of a lab experiment. You can see here on the gypsum on the left, a hard material, selective cracking, and then a very adventurous person with their soft tissue on the right showing no injury to that soft tissue. Again, the selective interaction with calcified lesions as opposed to normal tissue. So let's look a little bit at the clinical data. Most of us are relatively familiar with this, Disrupt-CAD3, the pivotal trial for FDA approval here in the United States, looking at lesions less than 40 millimeters, reference diameters of 2.5 to 4. Again, very successful in terms of device delivery, getting our stents in, having a successful procedure, very low major adverse event rates, the primary major adverse event rate being on blood draws on post-procedural day 1. And again, many of us don't do that, right, for our elective procedures because there's big heterogeneity in what does that actually mean. So again, the majority being driven by that, outside of ambiguous blood draws, relatively low complication rates. Another fun thing in the sub-study looked at the learning curve. So we had our roll-in patients versus our definitive patients in the trial. No difference in procedural success or major adverse outcomes. And that makes us feel really safe that this is something you can use right away. And that makes sense, right? It's just a balloon in some respects. We also saw that there was no difference in outcomes in terms of stent, MSA, other measures of stent expansion, whether you could see visible fractures on OCT or not. So again, this sort of leads us into this, wow, it seems to work in a lot of different types of calcium. We see it at 1 year. Again, if you take out the post-procedure blood draw, very, very low major adverse event rates at 1 year. Pooled analysis to ensure, does this work across various different types of studies, very different patient populations all over the world. Able to pool the data because very similar inclusion, exclusion, and endpoints. Again, we saw no difference across various study population in terms of procedural success or major adverse outcomes. We also saw that there was no difference in treating men and women, and this is very important. Everybody knows that we have a huge divide between the treatment of men and women with coronary disease. Women have typically worse outcomes and are undertreated, and to be able to take a potentially high-risk lesion subset and know that we can start to close that gap is key. This is a mechanism of action case illustration. This was the first case done that I was lucky enough to do after FDA approval. You can see a big rock pile and a very big right, where first we're radial. We've got a 7-French AR. This is a wire across gear won't go. Had to free wire with the RotaWire and microcatheter. 1.5 burr, and after the 1.5 burr, all we have is a 1.5 hole, right? We get the OCT catheter down and we can see there's very superficial fracture lines, but there is nothing done to the very deep calcium. There has been nothing done to the compliance of this. You're going to continue to fight this, whether it's NCs, cutting balloons, bigger burrs, whatever, because again, we haven't changed anything in the lesion. IVL goes in with no further predilation. This is a 4.0 balloon here, up and down the lesion, proper technique in terms of IVL delivery. You can see the angiogram now after IVL, and this is very different than our angiogram after rotational atherectomy. You can see again here on the longitudinal here, big fracture lines in multiple different planes in these big icebergs, right? And this is how we change the compliance of a vessel. Stent goes in, looks lovely. And again, this still shows you OCT after rota, right? Still heavy calcium, OCT in the middle after IVL, big fracture lines, and the stent continues to push those icebergs out of the way. This is how we treat calcified lesions. Now, what about nodular centric coronary calcium, thought to be potentially the Achilles heel of intravascular lithotripsy? Again, we have these protruding nodules. They make us feel uncomfortable. Do we need to wire bias, use these various types of atherectomy? Who knows? My stent looks weird on intravascular imaging because it's got this kidney shape like we see in the subintimal space. What do? Well, what we found, actually, this was presented as abstract a few months ago, is that there was no difference in our stent metrics, MSA, et cetera, in those with and without calcified nodules. The manuscript's currently been submitted, but it's very, very good news for us. There's so many different things that we used to worry about that are becoming much simpler with IVL. And again, it's getting towards this idea that my stent doesn't have to be a perfect circle, right? We don't have to worry about the donut. It's all about MSA, which is what we know drives outcomes. This is a case example. So this was done by my partner, inferior STEMI, left dominant system. Unfortunately, you can see there's inflow disease, right? There's a big nugget there in the distal left main. My partner goes on to treat the circumflex, but leaves the inflow disease. Now, not necessarily something I would have done, but this is just what was done, right? These are the things that happen in real life. The patient is sent upstairs to the CCU, and surgery is consulted about maybe doing a hybrid revas procedure to treat that distal left main. Again, interesting strategy. Was what it was. Surgery says no for a variety of reasons, and so my team was consulted, and we said, yep, we can certainly take care of that. And roughly 45 minutes later, the STs go up, the patient has chest pain, we bring him to the lab, and of course, our stent is thrombosed, right? Because we didn't take care of the inflow disease. We IVUS, we POBA, we optimize the stent, we fix that, and then it's on to the left main. And you can again see very calcified nodular. And you can see here a huge nodule in the left main as you come in. Wolverine simply wouldn't cut it. You're welcome for that. It's 8:35 in the morning, and you've had a very good pun. Take that with you for the rest of the day. Wolverine wouldn't expand at nominal pressure. IVL, after 70 pulses, gets full expansion. Stent goes in. We get an MSA of 11.5 by Noble criteria we look pretty good. So in conclusion, calcified coronary lesions will continue to increase in prevalence. There's a higher risk of major adverse events when treating them, but that risk can be mitigated with proper calcium solutions. IVL is a novel treatment for calcium in our calcium armamentarium. It appears to work in all types of calcium at this point, although we continue to have other types of investigations, bifurcations, left mains, with DCBs, et cetera. All of these things are currently ongoing. There are algorithms which Duane will get to here in a little bit, but the idea is if your imaging catheter can cross, great, shock it. If it can't, drill it. It's relatively simple. And always image. This is just a plug, has nothing to do with this talk, but please always image. The criteria of knowing whether you have severe calcium is often based on that. It will tell you exactly what to do, and it will help your patients get the best outcomes. Thank you very much.
So, Rob, a couple of questions. In your clinical practice, what are the clinical scenarios where you have seen where IVL has not worked for you?
Sure. You know, one of the challenges that we have is treating under deployed stents. I will tell you that you have to image, right, because IVL works on calcium. So if you have ISR from neoatherosclerosis or hyperplasia, right, that's not an area that's going to work. It's also got to be calcium on the outside. And remember, there is some mitigation of that therapeutic effect with one layer, although we still get pretty good results. The double layers where we really start to see it's a struggle. But the reality is it's a struggle with laser and many of our other things, right? We're really looking for MSA gains in the 1 to 1.5 area because that's really what we can get with many of our therapies. So I would say that's a big area, but a lot of the other areas, I mean, we've done a roughly 20, left mains, we've done a host of bifurcations, so we're finding all of these things where it works. Now, these are all one-offs, right? These are single individual experience. We do need to see the prospective data, but we are seeing a lot of places where it does work quite well.
Kind of been my experience as well is in-stent, stent under expansion or stent failures, eccentric stent expansion. It doesn't seem to work real well after the stents are in, particular if there's more than one layer. I usually go to laser first with that.
You've got to size your balloon correctly, though. We saw a case the other day at a conference where IVL was utilized. It was a 2.5 IVL balloon in a 4.0 vessel, and they were like, yeah, it only kind of worked. And it was like, well, it's not any different than sizing it to the coronary. So we just got to make sure we oversize a little bit. I think maybe with stents.
And on that note, how do you manage left mains? Because most left mains aren't 4 millimeters. Most of them are, 5, 5.5, 6.
So we still do get a field effect even when it's undersized. And we see this sometimes, right, because we only get 80 pulses. And so if you've got a tapered LAD, for example, and you've got several areas, we'll often take a 1-to-1 size for the distal area and still deploy it in the proximal area if we have pulses left. We will still get a field effect. Now, you really still need to ensure that you take an NC after that because you're not getting 1-to-1 apposition, but we will still get a field effect. There will still be, it's just like when we only deliver maybe 20 pulses and we might get a rupture in a circ. It's relatively uncommon these days, but we still get that field effect. It's just we need to have the NC to continue to push those fracture lines out.
So, Rob, and this is for the panel, and it's like we have now 3 devices for calcium ablation. I don't consider a laser as a calcium ablation device because it actually doesn't work against calcium. So we have rotablation, we have orbital atherectomy, and we have shockwave. And the question, you have a calcified lesion, and of course, the calcified lesion, you cannot cross it with an IVUS or OCT. You have to do something at the beginning. So how do you pick which device you go first? And do you go primarily with shockwave and then de-escalate from there to or escalate from there to other devices? Can you kind of elaborate on that? What happens when you see calcium in an artery?
Yeah, I don't want to, Duane's got a whole talk on this, so I don't want to, step on his toes too much in terms of algorithms. And
okay.
I'll go ahead and I'll extrapolate that. No, I think we want everybody to image, right? That's the goal. Sometimes we don't image, and there's a variety of reasons for that. So if you're not going to image, for example, if your NC balloon crosses and goes up and it doesn't look good at nominal, there's no reason to go to high pressure. We have technology for that, right? You're just pushing the boulder outside the artery. If you don't get across, is the question what type of atherectomy device you might use if you can't get across before shockwave, or do you need shockwave in addition, or?
So if the shockwave, let me just, because I don't want to step on Duane's talk. If the shockwave fails, what do you do next?
When you say fails, you mean don't cross?
No, it doesn't dilate the lesion, and that happens, not necessarily in the stents.
I will tell you that that is relatively uncommon for most of us. I will tell you that if you don't get that perfect expansion, if you still see a little bit of scalloping, that's going to be your classic time to take your NC balloon afterwards in order to spread the lesion more.
That's actually perfect. That has been my experience. Yeah. When it fails, I always go to the NC balloon immediately. Yep. And I remember the first time I started using shockwave, Dr. Kunkel on the back, she was the fellow, and I said, I'm disappointed. The shockwave didn't work. And she said, let's use the NC balloon. And amazingly, it worked.
I want to be very careful about the word fails, because just because it didn't perfectly expand doesn't mean it didn't treat the calcium and cause fractures. It just means that we have to take another device in order to propagate the effect that's already occurred. Now, this is different than a nodular calcium, right? You will often take, the data, it's not embargoed because it was on the TCT stuff and it'll come out in the manuscript, but you don't always see perfect expansion on a nodule. Doesn't mean there's not fractures, doesn't mean you still can't get the good MSA. And that's where, when I showed that OCT slide, we have to get used to the fact, like when we started doing subintimal PCI, we started imaging actually, right? We were doing reverse cart for a long time, then we started imaging, we get these weird looking stents, right? They get kidney shaped because the true lumen's kind of, and we were like, is this okay? We don't know. Turns out, we still had the same results as whether we were intraplaque or extraplaque. And the reason was we still had good MSAs. And that's the same thing with nodules. And that was the extrapolation for me. I'd already kind of gotten used to it in the subintimal space. And then I realized, even though the nodule still may deform the stent to a small degree, we still had a good MSA. And that's why the outcomes are still good.
Perfect. Thank you so much, Rob. That's a great talk. And then our next speaker, I know this is kind of the whole session. We're going to continue to discuss this, and there is a lot of opportunity to discuss and go back and make comments. So orbital and rotational atherectomy, step-by-step troubleshooting by our friend Mitul Patel, who comes to us from the sunny San Diego.
Thank you all, and thank you for the invitation. Robert's a tough act to follow, but I'll do my best. I also don't talk as fast as Robert or Dr. Berlakis, so there's a lot of stuff to cover here, so let me just start cranking through this. So I want to give Robert a little credit here. He and some colleagues came up with this calcium algorithm a few years ago. This was published in CCI. And again, just to enforce the point that he made about imaging, it's uber important in terms of how we manage calcium. Of course, if you follow this algorithm, many times it will lead you to mechanical atherectomy, which I'm going to cover in this talk. So the first device that was introduced in, I think, 1993 to manage calcium is rotational atherectomy, and now we have the newest evolution, which is Rotapro. For those that are unfamiliar, it comes in burr sizes of 125 to 175. Those can be delivered through a 6 French catheter. Once you get to the 2.0 burr, you need to go 7 French and higher. I will give you my opinion on kind of how I approach these and what guides I use to approach these. The mechanism of action here is differential cutting. So again, it ablates calcium, hard tissue, leaving the soft tissue unharmed usually. Speeds up to 200,000 RPMs, anywhere between 140 and 200,000. And the way that it works is really orthogonal displacement of friction, which for those that have removed a cork from a wine or champagne bottle, you understand twisting it gets you over the frictional forces in the longitudinal plane. And this is the mechanism of action of this particular device. It's delivered over one of 2 guide wires, either the rotofloppy or the extra support wire. The floppy is the most commonly used wire. It's 0.009 in diameter for much of its length, except for the distal spring tip, which is 0.14. The stiff wire allows for the use of this device and inducing wire bias. The floppy wire really eliminates a lot of the wire bias of rotational atherectomy, and I'll show you some case examples of this. This is the device. The console with the advancer button and the activation button are all in one there. You have the Dynaglide, which will allow for delivery of the device either through your guide and to the lesion safely. There are 2 ways to activate the Dynaglide button. There's one on the back that's opposite the brake defeat button, which you need to depress to advance that. And then you have this nice console now, which has your RPMs, which you can set, and it will also alert you if you have decelerations, which are important to try to avoid in terms of potential complications. Comes with a torquer. Most of us don't torque the rotofloppy or stiff wires down the vessel. It's usually delivered through a microcatheter. However, this device also serves as a brake defeat if you are, to stabilize the wire if you are defeating the brake with the brake defeat button. This is the setup. Basically, you have a gas supply hose that goes to the console, and then you connect the hybrid harness, which has electrical components, fiber optic components, to that console, which connects to your actual device that has the burr on it. You also have a port for saline infusion. Some people use Rotaglide. I think most people use Rotaglide. Dr. Pinto will talk potentially about his technique where he just used heparinized saline for this for the lubrication application of this device. So here's a quick case. This is an 85-year-old gentleman who presented with unstable angina. You can see he has a heavily calcified LAD, which was previously stented. He's left with the CTO here, which is also heavily calcified and quite angulated. You can see here on the left screen, wiring that microcatheter. I forget exactly which wire this was, but ultimately we were able to get through. On the right, you see the calcific burden. And of course, we imaged this, but couldn't image it until after we did rotational atherectomy. And you can see on the right, this is delivering the rotaburr with Dynaglide up and around across the left main into the proximal circumflex artery, which sometimes can be terrifying, but here turned out it worked out okay. This is just drilling that mid-circumflex. And what you want to avoid here is getting very close to that distal radio-opaque marker where the spring tip portion of the wire is, because you can fracture the wire there. So we can get into some of the troubleshooting here towards the end. This was the final result after rotational atherectomy there. Another case, and this demonstrates the use of this device in extremely tortuous anatomy. So this is a patient with end-stage liver disease who was being worked up for transplantation, was found to have this severe coronary disease and extreme tortuosity. This is an example of a case where you might go to a 125 burr. I know that that burr is most likely to get trapped if you're going to trap a burr. However, I couldn't really cross this with anything else. And so you can see this was very challenging to wire. The wire kept going into the diagonal branch. This is a dual lumen catheter attempt. Couldn't do it that way. And ultimately, with just a microcatheter, and I think this was a Xi'an black wire, using kind of the umbrella technique, pulling back, and then ultimately letting that wire flop into the mid-distal LAD. We were able to get it wired. This is the 125 burr. It's shaped a bit differently, not as much in the mid-body here, so less like a football, and that may induce some characteristics that can get it trapped. However, you can see here we were able to get through that without much difficulty. Nice balloon expansion, ultimate stent deployment, and a good result optimized with imaging. Moving on to orbital atherectomy. So this similarly is a device that rotates, and it rotates at two speeds, 80,000 or 120,000 RPMs. But because the burr, or the crown, excuse me, is eccentrically mounted on the catheter, it also orbits. So you get a larger arc of treatment, potentially, depending on the anatomy you're dealing with. And that's really its mechanism of action. It only comes in the one size for the coronary application, which is deliverable through a 6 French guide. These are the other components of the orbital atherectomy system. So you have the console, which is mounted on an IV pole, and then you can use the Viper Slide lubricant, which is recommended. That's connected to the console there. And then you have your advancer knob, which also has the activation button on it, and you have a brake on the back end to stabilize the wire. Again, something to keep in mind with orbital atherectomy, the force that you're imposing on the vessel is a product of obviously the mass of the device that you're using, but the velocity squared divided by the radius. So the velocity at 120,000, you're increasing your centrifugal force by 2.25, okay? So that's really important to keep in mind. And for most coronary lesions, you don't really need to use the higher speed. Some of the larger coronaries, or if you're trying to ablate a lot of in-stent tissue, you may go to the higher speed. But for most of the orbital atherectomy applications, you can get through it with lower speed. And this is really important with this particular atherectomy tool. So you want to go slow. This is done in a carbon block model, so if you go at a centimeter per second, you can see that in terms of the lumen that you are impacting, it's not that great, because the mechanism of this device is to really orbit to impact that surrounding tissue. Look at what happens if you go at 1 millimeter per second, so you get a lot more impact with your device. So it's really important with this device to move slow through the vessel. This is, again, some of the profiles of the catheter. And here's a case where we have a really ostial circumflex that's heavily calcified. The left main is actually okay, and the LAD is okay. And this is a scenario where if you want to induce some degree of wire bias, ultimately this was fairly circumferentially calcified, and we felt that with rotational atherectomy, we may not be able to impact all the walls of this particular lesion. Now, this is a pre-lithotripsy case, so ultimately we were able to perform orbital atherectomy and treated it with a provisional approach. We got a nice result. I think this next slide, or this movie, will demonstrate really the wire bias effect. So on the left, you see the rotational atherectomy device. On the right, you see orbital. And when you're coming around a curve, the orbital device may impact all sides of that vessel a bit better than your rotational device, unless you use a stiff wire and purposefully induce wire bias. So really quick to finish up, some troubleshooting. I think the main thing with troubleshooting, and all of us can attest to this, is really staying out of trouble, right? So most of these I personally do with the 7 French guide, not because you need a 7 French guide, depending on what device you're using and what size you're using, but if you get yourself into trouble and you need to parallel wire and balloon to release an entrapped burr, and you have a 7 or 8 French guide, you're going to be, that's a lot easier to do, and sometimes impossible to do through a 6 French guide. I mentioned the wire choices and what properties they have and what you can impact with that. Really important to have your antiplatelet therapy already on board, and if not, perhaps use some IV antiplatelet therapy. Vasodilators can get you out of trouble with no-reflow. Also, your speed, higher speed rotational atherectomy can cause more platelet activation and no-reflow, so really important to aggressively vasodilate. Using clean technique, so really pecking motions and not really leaning on your burr or crown to push it through a lesion. Allowing the tool to do what it does, which is ablate, sometimes just takes patience and time. And then, having your crap equipment available to you, so your covered stents, your tap kits, etc. Once you get into trouble, there are multiple ways of getting out. So stalled or stuck burrs, you use vasodilators. You may need to increase your speed to get it unstuck. You may have to just put some manual traction to remove it. I mentioned parallel wire, ballooning. You may have to cut the shaft of your device and rotate it manually and advance a guide extension over there to gain more traction to remove it. Dissections are welcomed usually, and those are easily treated with stents. Perforations, of course, we have covered stents, coils, and various mechanisms to seal those. No-reflow, I mentioned vasodilators. For things like wire fracture, again, avoidance is the best strategy, but if you happen to be in that situation, you can snare them, or you can just trap them behind the stent. And of course, if you are in a situation of hemodynamic compromise, you may need mechanical circulatory support. Same mechanisms of getting out of trouble, really, for orbital atherectomy. Not a lot different in terms of the technique, really. Again, I mentioned you want to go slow to really use the mechanism of the device to impact the calcium that you need to ablate. But other than that, really all the same ways of getting out of trouble. This was a nice little algorithm that came out of the Seattle Complications course, presented by Dr. Dahl and published in CIRC Interventions a couple years ago. It has mechanisms of getting yourself out of trouble in many complication situations, so I strongly encourage everyone to read this. Thank you.
Thank you so much. This is a kind of tour de force about these two devices. So can you just elaborate, when do you use for the rotational atherectomy? There are two kinds of wires. There is the supportive wire and a floppy one. So how do you pick which one to use?
Good question. So I think for the most part, I think 75% of cases or more, you're using the floppy wire because you don't want wire bias to be able to deliver your device and treat your lesion. The times when I use the stiff wire are for aortoosteal lesions, so osteal right, osteal left main, where you may want to induce wire bias, or in that scenario where I showed you the osteal circumflex lesion, where you really need to tug on the wire a little bit to impact the calcium and treat the calcium in different planes.
So do you think in an angulated lesion is like, let's say you don't want to, but an angulated lesion, is your default the floppy wire or the stiff wire, regardless of any other consideration?
I think it depends. I know that's a cop-out answer, but it really depends on where the angulated lesion is. For example, if you're really distal in a vessel, I think it's tough to get down there on the stiff wire. Sometimes you need the floppy wire to navigate the proximal portion of the vessel. But something like what I showed, that osteal circumflex or a left main osteal right, those are easy stiff wire cases for me at least.
I have a question for the panel.
Microphone for the faculty, right?
Anybody have a question from the
questions from the, just tell me and I'll come over to you if anyone has any question.
So to the panel, Louis, so what's your default guide catheter for atherectomy cases?
I have to admit I use almost exclusively 6 French guides.
6 French for all atherectomy, orbital, and
I do mostly orbital atherectomy, and I'm a radial first operator. And
Hey Sal, what's your default?
Guide size?
Yeah.
Yep, 6 French. So I think if you're going radial, typically we work through a 6 French system. Let me put it this way, that if I have a 6 French guide, that doesn't keep me from using atherectomy. I can use it, but if it's a CTO case, we're doing 7 French, even 7 French radial, then it sometimes makes it a little easier.
Okay, Stefan?
Well, in this era of slender sheets, to me, PCI is a 7 French by default. Gives you a bit more option, and in terms of size curves, in terms of curves, it depends what you want to do. I think getting something, I'm less enthusiastic about doing roto through an AL in the right if I think I'm not going to use, need too much support. I really like a good JR for the coaxiality of it, and XB's in the left.
So I want to ask the audience, who default is 6 French guide for atherectomy cases by hand? So, and who use 7 French? And who use 8 French? Okay. So
the decision on guide size for me has to do more with the other characteristics of the intervention, not the atherectomy, because you can use orbital and rota in IVL in a 6 French guide if you need to. It's really, most of these cases end up being bifurcations or left mains, and those are the reasons why you need, more support, more room for multiple devices, balloons, stents, et cetera. So,
so I was going to make a point about the guide shapes, that if you're using something close to the ostium, you want a guide that you can actually pull back and approach the ostium in a more coaxial fashion. So I think that's when a deep intubated guide that tends to deep intubate like an AR or AL becomes suboptimal. So that's, you want something like an EBU, which you can pull back, just push on the wire, and that will actually push the guide back enough so you can approach the burr.
Okay.
I was just going to say that the one advantage of an 8 French guide is if it's very distal, like you need to rota the PL because that's just terrible, is that you can put that through an 8 French guide extension. So I think if you have a high anticipation of that being pretty awful to get down to your target lesion, then sometimes I will go 8 French.
7 French, and if I'm femoral, I use a long sheet, 25 centimeter, to provide better support.
Great. We're going to go ahead and move on to the next top. Thanks, Mitul. Next up is a good friend, Dr. Duane Pinto, and he's going to be discussing on which device to use in which patient. And Dr. Pinto came straight from a case last night to the airport, and apparently his suits are not here, so he decided to wear scrubs. And I think all of us on the panel just think that he wanted to make sure that we knew he was an actual doctor.
Yeah, yeah. Well, my kids don't believe me. They don't care. But, yeah, no, I did finish a case late, and it was a choice between actually packing and getting clothes or making the flight. And didn't want to deal with the wrath of Berlachus and cancel late.
So obviously you are untucked scrubs. All of us are tuck scrubs.
I'll tuck in if it's for like a pitcher or something like that.
Okay.
But I don't feel like, But and I will point out, Jason, that Dr. Rinfret suggested using a JR guide for the right coronary artery. This is an inexorable debate that Dr. Wolmuth and I have. I say don't send a man in to do a boy's job for every case, but I don't know what you think.
Well, Dr. Judkins doesn't like me because I disparage his guides all the time. So.
Yeah. All right. Okay. All right. Well, let's get to it. Let's talk about how calcium impacts treatment decisions. An oldie but a goodie. A paper came out in 1995 where Cal and I were still in medical school, I think, then.
95? No, I was a full-fledged doctor.
Oh, I wasn't yet, so I'm actually younger yet than you. So this is paper, Marty and friends, Regina, I think you're probably involved in this. It looked at consecutive patients with target lesions around over 1,000 and looked at the prevalence of calcium and how things looked under IVUS interrogation. So around 25% had one quadrant calcification, half had two quadrant, 60% three quadrant, 85% four quadrant. The location of the calcium, around half was superficial, a quarter was deep, and a quarter was both. So, I think this helps inform us to know what we're dealing with. This is from Syntax, and I want you to bookmark this kind of idea that around half of the lesions in Syntax were heavily calcified. And you heard from Rob and Mitul that of all the issues with calcium and underexpanded stents, you guys all struggle with these lesions, and we do struggle with them. And the comment from Dr. Sharma and Dr. Keeney is Rota makes a lesion easier to deal with. I don't know why we're so afraid of it, to do it. I know why we're afraid of it, because we're not so comfortable. We don't do it that often, because I'll show you how often we do it. I was this many years old when I realized that there's actually formal criteria angiography to look at whether it's moderate or severe calcium. I was just used to looking at it and saying, that looks pretty calcified. But apparently there's a rule that if you see it without motion on both sides, it's severe. And if you see it on one side with motion, it's moderate. Do you guys believe this? No, either do I. And it's like when you're in a conference and the electrophysiologists are talking about, well, I think the blockage is just by the first septal, but just before the first diagonal. And I always say, there's a better test. It's called the angiogram. That's how we know where blockages are. If you want to know where the calcium is, how bad it is, there's a better test. You know what that is? Intravascular imaging. So those are the pictures on the right. In the middle here, OCT obviously helps you see the thickness and, as has been mentioned, the length of the calcium, whereas you're a little bit blinded by the calcium with IVUS, even though you know it's there. These are comparisons of what's been mentioned earlier: deep, superficial, concentric, eccentric, and calcified plaques. I think I would just keep this in mind as your adjectives when you describe this with intravascular imaging, which, as been mentioned, is, I think, obligatory when you're dealing with lesions like this. And then, as has been described, when you put something in a stiff pipe that doesn't want to expand, guess what? This thing doesn't expand. So as the arc of calcium increases, stent expansion goes down. So I asked you to bookmark the 50% of lesions that were heavily calcified in Syntax. Just do the thought experiment: if we didn't do a crappy job with the proximal LAD, whether we would have the same outcome in complex lesions in Syntax compared with bypass surgery, specifically the Lima. So and you actually saw in Rob's case that we don't need the stent manufacturers to make the stents better. You can push a stent through a severe left main lesion and get it to the distal LAD and then leave them alone and refer them for bypass surgery and wait for stent thrombosis. We don't need the stents to get better to put them in places where they don't need to go. We just need to do a better job at treating the lesions. So how can we do that? That's the subject of this talk. But here's the kind of denominator of papers showing that underexpansion is complicated by early stent thrombosis and restenosis, again illustrated by the case, including inflow problem that Rob showed. I'm going to start moving a little more quickly, but ADAPT DES, looking at target vessel failure, calcium versus not, more target vessel failure with calcium. And even in acute coronary syndrome, so acuity primarily a non-STEMI population, horizons a STEMI population, we say, oh yeah, the plaques are soft and we don't need to image. It's 2 o'clock in the morning. Why should I waste 3 minutes, doing this? But the prevalence of calcified lesions is not insignificant, even in this population, and the outcomes are not necessarily as good. Obviously confounded by the fact that people who have calcified lesions have a higher prevalence of renal failure and diabetes. But nonetheless, I think we all accept as interventional cardiologists that calcified lesions are more difficult to treat with more complications, but also our patients pay adverse dividends if we don't do a good job. So this is the outcomes of patients with calcified lesions for PCI in ACS. And you see a stepwise increase in things, and you could pay attention to stent thrombosis and TLR when it comes to calcified lesions in acute coronary syndromes. So, strategies to address coronary calcification. This is the most common strategy, as you know, in the United States, is to pretend like I didn't see the calcium and to just go on and continue to treat the patient as if it doesn't exist. But and I show you actual numbers. So we talked about the prevalence of calcified lesions, and this is the prevalence of I treat calcified lesions. So at least 5 years ago it was increasing, no doubt, but around 1/3 of hospitals did no cases with atherectomy, and you see the totality of percentages of atherectomy cases was somewhere around 3%. Let's see where it is now in 2022 and with lithoplasty as a treatment option. But nonetheless, as a general kind of thing to consider until I guess Rob's paper gets published, I think we can kind of change how we address the calcium based on its morphology. Nodular calcium, I think you're going to I guess, consider IVL. I'd like to hear what the panel thinks, but I tend to use more atherectomy if I see something that's a nodular plaque. Superficial plaque, I think you can consider any of the modalities like Cal. I'm not really a fan of laser for calcified lesions, even though it's on the list. And then if something's deep, I think it's fair to start with NC ballooning, scoring balloon, or cutting balloon with the idea that that plaque adjacent to the calcium is what you're going to be expanding, but you may need to treat the deep calcium, perhaps with intravascular lithotripsy, if you do not get adequate expansion. So this is a more complicated approach than what Rob showed earlier. It's not important to commit it to memory, but to take these take-home points, I think, and this is from the group at St. Francis, Evan and Richie actually put this out, that based on the morphology of the calcium, you might pick a different strategy. So this is predicated on the fact, too, that you want to take a thoughtful approach to calcium. Let me devise a strategy based on what I see in the vessel. So, if you see nodular calcium, perhaps you're going to default to an atherectomy strategy. And if you then image again, and I actually am interested again in the panel of whether you image atherectomy. I actually personally don't, I just proceed. I don't try to demonstrate whether there was fracture or not with imaging. And then, but I do a final picture to make sure that things are adequately expanded. If you see deep calcium, it's fair to start with a balloon strategy. If you see superficial calcium and you can cross, try lithotripsy. If you can't cross, then you're going to obviously have to go with something that will allow, help you deal with the balloon uncrossable lesion. And I also don't want to distract you from CVI, but if you're really interested in this topic, as it turns out, on Saturday at 9, Ron has a 3-hour fellows boot camp that is going to address these exact questions, including a primer on intravascular imaging from none other than Gary Mintz, and you're going to hear, and you could hear from Samin and others about atherectomy strategies and devices. And with that, I'll stop. Thank you.
Thank you so much, Duane. Panel, Stefan?
Just have a quick question, Duane. I've been doing that job long enough, so some people have gray hair. Mine are long. So
when I was your fellow, when I was first year fellow, when you were senior fellow, I didn't have this much gray hair, and now I do. How come you don't have any gray hair?
I don't know.
That like French genes, they stay young all the time.
The question is, I have a problem with some of these algorithms, and I'll show you what it is. Before IVL, what we would do, you'd see calcium, and there's been like multiple studies showing that dissection does not change anything in your outcome and doing rota. So now, like, you're gonna see like superficial calcium and everything, and I need to do rota right away. Why don't you go with a smaller balloon, a 2.5, and see if it cracks, and if it opens beautifully, what is gonna be the difference? If you bring your IVUS afterward, you'll see cracks and you'll expand, because you learned this morning that it's MSA that's important, right? So I think we are strongly influenced by industry to gear up. And I just want to warn us as a group that beside the MSA and the final result linking with outcomes, there's no data. But I totally believe in the fact that you need to do a good job. But the sequence in doing it, I think balloons have been wiped out of the equation too fast. That's my humble opinion.
Yeah, I mean, I'm with you, Stefan, but don't forget we're a little bit in the echo chamber today, in that our problem is, so first of all, I'm moderately allergic to algorithms. I agree with you. They're not rules that have to be followed blindly, but it's a schema that I keep in my head so I don't persist in a failure mode. Yeah. So let me know the options. But if we've already said, we're going to image and make a decision, and we're going to see if what we're doing worked, and if it didn't work, I'm going to do something else, we're already better than 90% of the time of what exists now, where most people are not engaging some of these options. If you want to use balloon first, if you, before you move to Emory, if you in Canada could get OPN balloon and dilated 35 atmospheres, we can't get that in the United States, go ahead. Yeah. But if it doesn't work, as Cal said in these other scenarios, what you going to do, then you better have a strategy for what you're going to do.
So I'll be the devil's advocate here. So Stefan, I'm actually with you, but there's one caveat. What would you do if you induce dissection? Use the balloon ruptured and dissected the vessel. So now, are your hands tied behind your back?
I mean, you're the crazy guys that dissect things and then purposely rota. I mean, come on.
Yeah. That's true.
Yeah. The point is that I think what Duane said, not persisting in the failure mode, is very important. So you're not going to go with that. Let's say I'm going to go 2.5 and I'm up at 22 atmosphere, doesn't crack. Let's get a 3.0 and then go at 22 atmosphere, it doesn't crack. This is, now you're getting into doing something that doesn't work. However, if you're not using an oversized balloon and you go to reasonable high atmosphere, and you can actually see how the plaque behaves, and sometimes you're very surprised. So you're 2.5, everything opens nicely, and then your case is $3,000 less expensive right off the bat.
Absolutely.
And you have to think about it, and you're not paying a toll if you're not escalating in your balloon strategy, but I tend to disagree with gearing up right off the bat.
So I want to give two things, though, as strategy pearls of don't fall into the sucker bet trap. So Stefan mentioned one, which is I dilated with the 2.5 balloon, got a dog bone that you saw in the cases. Let me go with the bigger balloon. That doesn't work. So a bigger balloon for something that doesn't expand is not the strategy. You get a shorter balloon and you try to go to high pressure at that spot. But a bigger balloon doesn't make the undilatable dilatable. In fact, it just increases your risk of rupture. That's sucker bet number one you should not do. Number two is, let me just put the stent in and then I'll post-dilate to high pressure. Never do that, because I've done that, it doesn't work. And you just get boxed into a problem.
Sal, you want to say something?
No, I just want to say that, and Cal may have been the last fellow at Auctioner to have done brachytherapy because it was done by the time I started fellowship. But the principle for calcium modulation is a bit like brachytherapy, where if you remember, we deliver the therapy and then we expand it. So sometimes, the choice of device becomes on what's going to get most interaction with the calcium. So sometimes if the lumen that you have is wide enough that a 1.5 burr is not going to do a good job, you can go with a rotational orbital atherectomy. And that's the point where if you can get a balloon across, then start with IVL. But ultimately, the thing is that you have to be sort of more flexible in your thought process, and there are times where you have to choose different strategies. So there are cases we've done, start with IVL, it didn't work, then used a cutting balloon or something to get the IVL a little deeper, or perhaps use atherectomy, and then do IVL again. And there's a multitude of combinations you can have with these atherectomy choices, which goes back to a point which was made in one of the morning sessions, that this is something that specialized centers should actually focus on, and having all of the tools that you need and operators that are facile and comfortable. So not everyone has to be comfortable doing everything, but at least one operator should be as good as Duane or Cal or Stefan, comfortable, so that when you guys, when your colleagues can't do it, then they can call on you.
But as a strategy kind of thing, something that the CTO operators, Kate, Jason, all you guys have taught me is decrease the activation energy to pivot in strategies. So be prepared to switch to retrograde is translated into this talk in calcium is be prepared to switch to Rota. Be prepared to finish up with IVL if you have to. Be prepared, and don't say, oh, I'm just going to keep on ballooning, and now you're 45 minutes in and 200 of contrast in and everyone's tired, and now you're even harder to get going with atherectomy.
So this is interesting discussion, and well, we're going to move to the second presentation. Thanks, Duane. That's really great. Our friend Yader Sandoval going to actually present a case example for us here, and hopefully we'll take more discussion. And I still have burning questions for Kate in my mind, but we'll ask it after the presentation.
How's it going, guys? All right, thank you for the opportunity. It's really a pleasure to be here back in person. And I actually think that debate about balloons versus atherectomy and so on, it's a great introduction to this case that I'll share here. Again, this is a case-based presentation, so hopefully we'll invite some of real-life challenges. So I think this case, as I'll summarize, really goes over three things. I mean, I'm an image-first guy, but sometimes the image catheter doesn't cross. So we'll talk a little bit about that. We'll talk about circumferential calcium and some of the challenges in decision-making. How do we decide going balloons versus more atherectomy devices, as we were just discussing during the debate? So here's this case. This is the entire talk is about the same case with multivascular coronary artery disease. This is a 70-year-old patient that has exertional angina despite medical therapy that actually had a coronary CT showing severe calcific multivascular coronary artery disease involving the middle AD and proximal and mid RCA. As you can see in the angiogram, it has pretty severe tight middle AD at a very tortuous angulated segment, actually pretty bad tortuosity, as you can appreciate that there. There's some hazy proximal RCA. There's a disease in the proximal as well as in the mid RCA lesion. So what do we do here? We're thinking, well, should we think about bypass versus PCI, or these lesions that we can't get a good result with PCI? In our thought in this particular case is, well, this is not left main, and the lesions are probably amenable. We talked to the referent and we said, we can consider PCI, even though it would be high risk and calcific. And if we're gonna do PCI, how do we do this? Do we modify plaque with balloon angioplasty, or do we think about upfront atherectomy? Again, you're looking at that very tortuous calcific at LAD, and whether it would be safe to do some sort of aggressive atherectomy there. And of course, we're thinking, can intracoronary imaging help with decision making? So we're thinking about all these things as we're doing this case. So what did we do? We first proceed with, after talking to the referent, we said, well, we can do PCI here, and we think we can provide a reasonable result. We wire here with a workhorse wire, and as you can see, we get some vessel straightening, a bunch of pseudo lesions that you can appreciate there. And initially, our initial approach is to try to do imaging first. At this particular point, I don't know whether you guys are struggling with this in your lab, but there's the recall on the Obster catheters from OCT. So actually, the Optus there's a national shortage. I don't know whether your labs are dealing with that, but we're short on OCT catheters. I try to get an eagle eye doesn't cross. We get an NC balloon, and actually, this is an NC balloon, as we were talking about before during the debate, like 22, 24 atmospheres. And actually, we break this calcium, and we get a reasonable balloon expansion. So therefore, we go ahead and essentially proceed with guideliner-assisted stent delivery. As you can see, pretty good expansion of that lesion right where that calcium and tortuosity was. And as you can see here, we get a pretty satisfactory result. So we're moving ahead. We said, all right, perfect. We avoided doing rotor CSI in this lesion. And again, while I'm a big believer in image-first approach, sometimes you can't get the catheter through. So now we move to the right. Here we go with an AL guide. Same thing. In some of these lesions that are calcific, this is just my approach. I like to get a supportive wire, microcatheter, carabel, switch for a wiggle wire, get nice support, and we start here with IVUS. And as you can see here, I don't know whether the video will play, but essentially there's circumferential calcium. This is our initial step before doing anything. So we're thinking, what should we do first? I mean, you'll see it here when it plays. Essentially, there's going to be this. Essentially, looks almost like a stent right there. Just horrible circumferential calcium. And we're wondering, should we do CSI? What should we do next? So in this particular case, we went ahead and we go ahead and we say, well, let's try IBL first and actually do that as an initial upfront approach. So we did IBL 3-5 millimeters as close to 1-to-1 as we could. It's more like a 4-0 vessel. And as you can see there with a 3-5 in the initial cycle, there's still actually some pretty reasonable balloon under expansion. We give at least 50 pulses here. And as you can see now in the post-IVL and in that area, it is a little bit better. Still some under expansion, and we give the other full 30 pulses to the whole therapy in the proximal RCA. You probably saw that mid-RCA, so keep that in mind because we still have some residual disease in the mid-RCA. And again, in this particular case, I think something that, in retrospect, we could have potentially done different is we're thinking, should we do the proximal RCA and treat the inflow first? And that's something that we're going to have to think of forward moving in the case. So we do the IVL. We say, okay, we get good expansion. And this actually, in this case, I don't do this all the time, but in this particular case, we decide, all right, let's get the IVUS before further preparing the lesion. And it's interesting, I think Rob, if he's still around, he actually showed some examples of this, but we actually documented with the eagle eye some nice calcium fractures in several areas. In that particular area that had that very bad circumferential calcium. So we feel good that we've done some plaque modification with that IVL. At this particular point, now we go with a 3-5 NC, and this is again high pressures, 20 plus or so, and we're very happy. We're moving forward, a nice lesion modification with the NC at high pressures. So we're feeling good about this. And now we go ahead and stent this IVUS guided, and we stent the proximal RCA. So we're like, all right, reasonable result. We did a 3-5-4-0 optimization, high pressures. But here's where, in retrospect, we could have done things a little bit differently. We focused all our IVL therapy in that proximal inflow lesion that had that circumferential calcium. But there's still it's pretty diffuse, heavily calcific mid-RCA disease, and there's that shelf of calcium right in the mid-RCA that we have not yet treated, and it actually looks pretty hazy here. We didn't treat that beforehand, but as we evaluate that further and look at IVUS, there's a pretty bad spot there of circumferential calcium there. Now we've used our entire 80 pulses from the IVL on the proximal RCA. So the question is, what do we do next? Which I think follows nicely this debate of IVL versus just regular balloons. We wire again, microcatheter, switch for a wiggle. We just take an NC and just go here like 25 atmospheres or so. Just breaks up, expands right away, no problem, even though it's totally circumferential. Put a long stent, expands very nice. So again, showing an interesting thing that I think there are opportunities to improve our risk prediction tools because I'm showing two circumferential calcific horrible lesions, one in the proximal RCA and one in the mid-RCA. In the proximal, we use IVL, which I think was appropriate, but there I had another one in the mid-RCA, and we just totally expanded that very nicely with high pressure and C balloons. And I think, to me, it speaks to the opportunity to improve the algorithms to predict when we use these tools. And this is essentially our final result with a couple of stents in that RCA, and IVUS show good expansion, good apposition, no distal edge dissection. So take-home points to me are that, yes, I'm an intracoronary imaging first advocate. However, so my rates are like, 70, 80% or so, but it doesn't work all the time. Sometimes I cannot deliver the catheter. There are some lesions that are heavily tortuosity, bunch of stents, difficult to cross. You get a lot of NERD with mechanical pullback on either IVUS or OCT. So there's some potential challenges that I think need to be considered that sometimes we don't talk about. Sometimes with the with supportive wires, particularly with OCT, you can get a lot of non-uniform rotational distortion. So it's not always perfect. And in this case, again, we didn't have HD IVUS, but Eagle Eye would not cross. So you have to make decisions at bedside. So again, you have to consider these trade-offs. And I think it really follows nicely the debate that just occurred. We need better prediction tools. And I think a case like this that had multivessel disease with calcium shows how some lesions we can get some balloons, some we need IVL, and some lesions show the same phenotype with concentric calcium, but we need to understand when to better use these tools. Thank you so much.
Thank you so much.
Yader, that was a great case, and I love seeing that case and how you did it, because I'm thinking in my mind when you showed those pictures of what I would have done differently. And so I think we'll go through the panel and kind of just have a, not so much a debate, just a different approach.
I think there's multiple ways to do this case.
But the thing I will say is you can't argue with that result. It was great. But my first question was with that LAD lesion. You were able to get it to expand nicely with a balloon and didn't have to jump to a more aggressive device. But occasionally we'll get into a situation where we've got a really tortuous lesion, and you're always a little bit nervous about doing a mechanical atherectomy device with severe tortuosity. And in a case like that, oftentimes IVL is harder to deliver, again, because of the calcification tortuosity. So how do people approach severely tortuous lesions where you need to use mechanical atherectomy? What's your preferred device?
So I actually like the orbital atherectomy in these devices, especially the new wire in these lesions, because the new wire, the flex, the Viper flex is actually less likely to cause a wire bias. And I use the like similar Dynaglide, Viper Glide. I can advance the device as much as I can, and I will never go to high speed. Now, let's say if there are some labs only one device, I will actually use the floppy Rota wire, the same thing, and advance it. One of the things you can overcome tortuosity if you have enough room to actually use a guide extender, put it all the way down, and deliver the bird through it. But I agree with Yader strategy, like using balloon. That was excellent outcome with it.
Yeah, great. Anybody else have a different strategy with a very tortuous lesion? Sal?
Yeah. No, I was will make a plug for nothing to do with atherectomy devices, but guide extenders. I think this is a great use for guide extenders when you want to deliver equipment in vessels which are unfavorable either from the get-go or sometimes even with tortuosity. You can use a long balloon like a 2.0 or 2.5, 2.530, and then inch worm across. And once you have your guide extender across, then you can deliver your IVL and unsheath the device. That's one technique. The other thing is, and I think Kate pointed out to this, that if you're using atherectomy, especially rotational atherectomy, there may be a bigger guide extender, something like a 7. If you're using a trap liner, then definitely use a 7. If you use if it's a regular guide extender without the balloon attached, then you can use even a 6 French. But guide extenders will solve the delivery option, but then you have to withdraw the guide extender into the guide before you start doing whatever you're doing.
So one point that I wanted to make, I see a lot of fellows here in the audience. In this type of lesion, you don't want to go for an MSA of 7 or 8. Your vessel can easily dissect all the way to the apical LAD. When you have this 180-degree hairpin turn, you have to be a little bit conservative at the stent edges and just be careful. This is not your prox LAD where you want to achieve the maximum MSA. You just want to get a very good result. But you have to be cognizant not to have a dissection that propagates all the way to the apical LAD.
Kate, I have a question for you. So that mid-RCA lesion, let's say the balloon dissected it but did not expand it. Now what?
Well, I think that's where IVL really has helped change some of these strategies because you just have a fresh stent, so you'd rather not deliver atherectomy through that. We have had some cases like that where it was a non-atherectomy institution sent over and we delivered a guide extension down to then kind of bring your atherectomy device. But I think after your fresh stent is in, that's where if the NC isn't working, then I think that's nice. That's focal enough that a lot of times you can get that with a balloon, but I think, you know, what I always telling to the fellows, especially if it's a balloon forward strategy for calcium, when that gives, especially if it's nodular and eccentric, you know, the next thing you should be thinking is, well, at least I can deliver my covered stent if I need to, because you don't know exactly where that's going. So if we haven't really modified it, just getting expansion is not always enough. But something focal like this, I think a balloon's a good thing to try.
So I'm going to put you in a spot here. My administrators are now coming, like they want me to put an algorithm for using IVL balloons. So I already spent $4,700. And the device did not. So I only can use the cheapest of the two atherectomy devices, which is rotablation, $1,800 versus $3,000. So would you use rotablation, and would you modify, now you have a dissection, would you modify your burr choice and technique?
Yeah, I think when we have bigger dissection planes, then I really prefer to stay with a 1.5 burr, and part of that comes from experience in the subintimal space where we know we have a big dissection, and every case that I'm aware of where we've tried to go bigger than that, we have a massive perf. So I think learning from that experience, in some of these cases, there's probably dissections we're not seeing because we're not taking a lot of pictures and things like that, and that's where you just have to have really impeccable technique. But I do think from a mechanistic issue, if you're using atherectomy, rota probably is favorable over orbital if you know you have a dissection in terms of perf.
And I will go lower speed.
Yeah.
So that RCA kind of brings up another situation where you've got severe diffuse disease along a long segment, and what's your approach to that? You know, I looked at that case and I would have approached it very differently. And again, I can't argue with the result that you had, but I'm curious how other people approach long lesions and what is their upfront device. That's been one of my concerns with IVL is you pick a device that may be sized for a distal lesion, maybe it's 2.5 or 3.0 distally, but more in the more proximal vessel, it's 3.5, and then do you spend the money to put another $5,000 balloon in, or do you use a different device up front? How do you guys approach long lesions, tapering lesions?
Maybe I'll briefly speak to that. I think it's an excellent point. I think that initially, for whatever reason, we got tempted to treat the proximal inflow first. In retrospect, of course, we treated it all, and I think if one had to go with back long lesion, I think going with a 1.5 burr or bigger 1.75, just treating the whole thing would probably be a very reasonable approach, or even CSI. In this case, I think we did the IBUS up front. We got distracted by that proximal arterial circumferential calcium and went up front to that. But clearly, we ended up treating the whole thing. Fortunately, we were able to get the stents to that mid-RCA with no problem whatsoever. But as we all know, sometimes it's hard to get equipment distally once you're already stented proximally. We always ideally want to stent distal to proximal. But I think that's a real deal. If we had issues, I think one can get a guideliner and just get CSI distal to the stent.
So Lou, you have a comment?
Yeah, I was going to just follow up on that interesting right. Were you able to get your eagle eye catheter to that mid vessel, or did the calcium burden in the proximal vessel?
Get what?
Were you able to image the mid vessel?
Yes.
Okay.
Yes. Yeah, we got it. Yep.
Yeah, and I think speaking to some of the points that were up here, I am in a resource-constrained county hospital, and we actually don't have IVL. We'd love to have it. Our administrators have said you have rota, we have orbital atherectomy, which is sort of my default because of its ability to do some of these long lesions like this right. And our administrators have said, well, do you really need a third thing? And financially it's a fair point, but I think as has been presented here, they do have potentially different applications, and I think kind of figuring out how to both use them aggressively and appropriately, and also prove that to your powers that be is one of our jobs going forward.
Stefan, have a comment, and then we're going to go to the next speaker. Thank you.
This case illustrates a bit what I was saying. Like I don't know if just a plain old balloon proximal and in the mid right when we've done the whole work and in the end get to the same result. And I think you don't, especially if we have superficial calcium, and to the point, like when you have a long lesion, lots of calcium, I agree with Jason. I tend not to choose IVL first because I know I'm going to have to treat on a long distance, right? And I like CSI for this. It gives you a bit more room, and especially when you have like superficial calcium. In superficial calcium, if you look at all the algorithm, everything fits. It's just the deep calcium where you have to find maybe something that's going to work better, and nothing can beat IVL for deep calcium if you're really worried and your balloon's not expanding. But for superficial calcium, we have more choice.
Great, thanks, Stefan. So next up, we have Katherine Kunkel. She's going to be speaking about the pitfalls of calcified lesions and what can go wrong. And she gave an awesome talk yesterday to the Fellows Boot Camp about perforations. And she's been in practice down in Atlanta for the last year, but trained with Dr. Aliswad, who taught her how to make perforations and make complications, apparently. So
that's a shout out.
Cal.
Fortunately, you'll only recognize maybe one of these cases. The rest of them are my own. Hi, everyone. Nice to meet you. I'm Katherine Kunkel. If I could grab my slides. Okay. So these are my disclosures. So not to state the obvious, we know that calcium is associated with badness, right? These are the patients most likely to have MI and death. And we know that when we try to fix them, these are the lesions that do the worst. They do the worst in ACS. They do the worst in stable ischemic heart disease. And for that reason, we have to get a little more aggressive here. And we've spent the last couple of hours talking about all the ways in which we do this. And at the end of the day, it works. Right, so we know that calcium modification facilitates stent delivery and expansion. We know this with orbital atherectomy. We know it with Rota. We know it with lithotripsy. But this comes at a cost, right? And so we're going to spend the next seven or 8 minutes talking about the plethora of bad things that can happen as you go toe-to-toe with these vessels. So first, no-reflow. One of my personal least favorites because we have so few options for this. We know this is microvascular obstruction at the heart of it. And while this happens, especially in our late presenting STEMIs when we're working with vein grafts, really calcium is a major enemy here. All of these problems have their own algorithm. And so when we're thinking about no reflow, especially in calcium modification, you often end up down this pathway where you're administering medications locally or via a dual lumen microcatheter. So I'll show you this case, which I will tell you was my very first case as an attending. And so you see this long calcified lesion in the proximal to mid LAD. Do IVUS, do all the things you do. Of course, the eagle eye doesn't cross, but we get an idea. We've got concentric calcification. This is what we have after CSI. Oh no. After ballooning the lesion, did IVUS, didn't learn anything really about dissections. Put a microcatheter distally and saw, again, this idea that the dye is just hanging up. Essentially gave the whole pharmacy down. So these are kind of the no-reflow medications. I've listed kind of a lot of these talks will have what the dosage range. So I've told you what I give in these sort of situations. So I tend to give 5 milliliters of adenosine, which is kind of in my lab. I know that I happen to have verapamil on the back table if I've done a radial case. For the radial sheath that's in the concentration, I need about a half cc. I don't tend to give much nicardipine. I usually start with 200 to 400 of nipride, depending on the patient's blood pressure. But epi has really been a big change for me and something that's been incredibly helpful in these situations. But alas, despite all of that, after about an hour of work trying to get this to work, this is the final result, which is pretty upsetting, especially when you're at a new institution. This is your first case as an attending. So fortunately, this patient went to the ICU. He did great. He came back a month later for repeat angiogram and intervention and ultimately ended up with a great result. the next major complication we'll talk about is perforation. And so, as was mentioned, this is its own topic. But know what the risk factors are. Calcium and atherectomy, not just atherectomy, are potentially major risk factors here. And at the end of the day, when you're dealing with calcium and a perforation, it's usually a main vessel perforation. And so this is when you're working your way down the main vessel perforation algorithm. So I'll show you what this looks like. This was a surgical turn down involving the circ and the LAD. Ultimately, we're able to expand everything with balloons, set up to do a mini crush of the distal left main, stented the LAD, finished it out, did a kissing balloon, post-dilate everything, gave yourself a high five. What's that? And so this is one of those examples that, as was predicted by the panel, a piece of calcium was just pushed outside the vessel and a perforation happened. The next step, of course, is balloon tamponade, which is incredibly important to stabilize your patient. And so the question here was where to covered stent. And so taking a lot of pictures, trying to understand where exactly this perforation is, deployed a papyrus, and had ongoing bleeding. And this was an effort to try to not get involved in covering that diagonal, but ultimately needed to cover the diagonal and actually did maintain TIMI2 flow in the diagonal and had resolution of this, and this patient did quite well. Next is vessel dissection. And so there's a lot of different ways to do this. I'll show you a couple of them. But ultimately, the idea here is sometimes you actually obstruct coronary flow, and this can be one of the acute vessel closure cases. So again, we're working down this, this dissection algorithm. And so this is what that looks like. So here is another left main into LAD. And so orbital atherectomy was performed. You're feeling really good about yourself. And then this happens. And these aren't fun cases. This is a patient getting massive ST elevations on the table. And so I kind of started working my way through the algorithm because I didn't see a clear, obvious dissection. Started with a balloon to see if that would help. It didn't. IVIST, I didn't see any major dissection. Gave a lot of meds, and this was after giving medication. So again, still really no flow. So ultimately made the decision to stent the inflow because perhaps there was a dissection that I was underappreciating, and that ended up being the answer, fortunately, and this patient did great. So I think for me, this case in particular was a big lesson of calcium modification and the inflow and recognizing dissections in the proximal portion of your vessel. This was another fun case. So this was a case in an older woman with end-stage renal disease who had severe aortic stenosis. And so this is one of those pre-TAVR angiograms. You find a focal nodular calcification in the mid-RCA. I said, okay, no problem. We'll just shockwave this, no problem, except nothing would cross, right? And so I said, okay, I don't know that this is something I want to get into right now, doing atherectomy, especially around this shepherd's crook. I think, we'll take this picture and be happy with that we haven't heard anything, do a TAVR and come back to fight on another day. Unfortunately, that's not what happened next. And so this was a big lesson for me in how calcium grips wires. And so as I was pulling the guide wire, it pulled the guide in, and this is that kind of cutting cheese wire effect. And you see I have a spiral dissection of the entire proximal to mid-right coronary. So not a fun situation to be in. The patient's getting quite sick. And so you won't see any pictures after this because the major key that Cal taught me is to stop injecting. So no more pictures. We're ultimately able to rewire this with a workhorse wire, deep guide extension. And so now you've got your wire across, your patient's sick, but you still have to deal with this uncrossable lesion. So this is kind of one of those situations I was really happy that I was in with a 45 sheath from the groin with an AL guide and was ultimately able to get a microcatheter across, exchanged for support wire, ballooned a lot, several balloon ruptures, but ultimately was able to salvage the case. And this was the final result. So just be aware in these moments that there are a variety of ways to induce dissections and don't make the same mistakes I have. And then equipment entrapment. So I know we talk a lot about burr entrapment. That's always a crowd pleaser. But know that there's lots of things that can get entrapped in calcium. Stents, wires, microcatheter tips, and burrs. And calcium, but especially calcium with tortuosity, poor lesion preparation, all of this stuff goes together. Each of those has its own separate algorithm. And so this is kind of one of those moments where you really have to go, and if you're going to be taking on these sort of cases, kind of be ready for each of these potential complications. So this was an RCA CTO that was actually relatively easily crossed antegrade. A guide catheter extension was advanced to the lesion, and ultimately, couldn't even get a microcatheter across. There was just this very tight focal lesion. And so ultimately, primarily wired with a rotowire to the distal vessel. But here, you can see rota is going on, but ultimately the burr becomes stuck in the mid-vessel. And so this is that technique where you pull the rotowire back and take advantage of the size difference between the distal rotowire and the rotowire body to pull the whole device as a unit. And so in this case, that was effective. You take a puff and see what you're left with. Fortunately, in this case, there was only a small dissection and no major explosion. Was able to modify the lesion with non-compliant balloons. And this was the final result. So at the end of the day, if you're taking on calcified vessels, which I'm sure we all are, be ready, because when you push at these arteries, sometimes they're going to push back. The panel's been talking about a lot about access and guide choices. The idea of don't send a man to do a boy's job. I definitely fall much more on the come loaded for bear side of the debate. Just recognizing that these are the lesions where you're more likely to end up in trouble, and man, you don't want to end up in trouble with an unsupportive guide and in a French size that doesn't give you options. Be vigilant, right? Know the complications, they happen, and the consequences of these grow over time, right? So the longer you don't acknowledge to yourself that this complication is happening, the worse the consequences are going to be. And know the algorithms. They will give you options to get your patient out of this. Thank you.
Well, Katherine, you make me proud. All these complications are not mine, obviously.
Definitely not.
So I actually, yes, but just one comment. I never felt like I wish I used less supportive guide, and you demonstrated that elegantly here in your cases. And if you had 6 French guide catheter and these complications, you would have been really up a creek. So because we don't have much time left, we're going to move to the next speaker. Hopefully we'll have some discussion at the end. And Katherine is in the back, so if anybody have a question for her, well, she'll be there. Okay, the next speaker is Dr. Megha Prasad, and she will speak to us about imaging to guide therapy of calcium lesions, which is can been alluded to all through, but nobody kind of went elaborated on it. Megha?
Thanks. So I'll be talking about imaging calcification, and we're going to put a spin on this with ultra-low contrast PCI, because a lot of the things I was going to talk about I knew would be covered in the session already. These are my disclosures. So I have 3 main objectives today. First, to demonstrate the role of the calcium score in predicting the need for calcium modification. 2, to identify calcium fracture on IVUS and OCT. And 3rd, to go through a stepwise approach to treatment of the calcified lesion, which often is in a patient with CKD as well. What do you already know? You know that calcification is associated with procedural complications and stent restenosis. You know that the assessment of the degree of calcification may be difficult with angiography alone. And you know that IVUS or OCT can help guide treatment plans and is very important. And that's what I hope to convince you of today. Why image calcified lesions? First, to predict stent expansion and choose appropriate tools to prepare your lesion so you don't have an underexpanded stent. 2, to detect edge dissections and or stent underexpansion after you've deployed a stent. 3, to increase your confidence in managing calcified lesions, and this is specifically to be able to identify calcium fracture before you deploy a stent so you don't end up with an underexpanded stent. And 4, to perform PCI with minimal dye. So first, let's go through 2 different calcium scores that I use every day. One is the IVUS calcium score. This was published recently in Circ Interventions. And basically, what this says is if you have angiographic calcium, when you look at your angiogram, you want to look and form an idea of what your calcium score is. Do you have a calcium arc greater than 270 degrees for longer than 5 millimeters? Do you have areas of 360 degrees of calcium? Do you have a calcium nodule? And is your vessel diameter less than 3.5 millimeters? If you have greater than or equal to 2 of these things, you want to consider atherectomy or IVL. Now, there's also an OCT-based score as well, which again looks at angle, thickness, and length. Again, 5 millimeters of length, 0.5 millimeters of thickness, and an angle of greater than 180 degrees. So this is an example of a case where the calcium score was calculated to be 2. It was treated with rotational atherectomy with a 125 burr and a 1.5 burr and then NC balloons. And you can see here calcium fractures where the calcium is separating, and you have a good final result. We'll go over that in more detail. There's several studies that have shown that maximum calcium angle, maximum calcium thickness, and calcium length are all predictive of stent expansion, and that these calcium scores that have been developed can predict stent expansion. So how do we identify calcium fracture on IVUS and OCT to prevent stent under expansion? So this is on IVUS. You can see here, post-ballooning, you can see separation of the calcium. And when the stent is deployed, you can see that there's significant vessel stretch and that the stent is well expanded. On OCT, you can see here again, and it's more easily visible sometimes on OCT, you can again see stent expansion that's sort of expanded very well with an MSA of 7.5, and again, separation of the calcium. Here's a case of an angiosculpt, and I typically, when I do an angiosculpt after I NC balloon, I'll take a look and look for these scores because that again will help predict good stent expansion. So let's go through a stepwise approach to treating the calcified lesion. We've already heard a little bit about this, but if you start with imaging, if you can't image, then you want to get your imaging catheter across. That I do with either balloon or atherectomy, and then I stop, image, and calculate a calcium score. Once I have my calcium score, I decide on whether I need an IVL or specialty balloon or atherectomy, or whether I can go just with NC balloons. Once I've prepared the lesion, I then image again. This is probably the most important step because once you've prepared your lesion, you want to image again and make sure that there's calcium fracture. If there is calcium fracture, you stent and optimize and then go on with your final imaging. Some things to consider. IVUS has certain pros. I use it a lot in my practice because I do a lot of minimal contrast PCI, and sometimes it can be more available and operators can be more comfortable with it. But OCT has significant pros. First of all, you can co-register, and that can help you minimize dye. You can use saline OCT, so that can help minimize dye as well. Image quality is fantastic with OCT, as we know. And anytime there's stent failure, where I see a lot of cases of underexpanded stents or in-stent restenosis, those are cases where you really want to use OCT, and then OCT can help you more with the depth of calcium. So we'll go through a few cases. This is a case I did a few weeks ago, a 6 French GR4 guide with side holes, a mid-RCA calcified lesion. I started dilating with a Takero balloon and then a non-compliant balloon and had a significant waste. And so we went ahead and OCT'd the vessel, and you'll see here, I look at my distal reference, I make sure that I can size my balloon appropriately, and then you can see a significant calcified lesion with a nodule here. And I calculate my OCT score, and I know that my OCT score is 3 based on that, and so I go ahead and take a shock wave and deliver that with 40 pulses. I use my imaging catheter always to mark where the nodule is, and so on co-registration I can do that, and that really helps in this era of IVL of delivering your pulses at the exact correct location to help minimize wasting your pulses, as these are expensive devices. So I post-dilated then with an NC quantum balloon, and you can see here just on the longitudinal view that the stent is well expanded. And this is the final angiogram. So shifting gears a little bit to ultra-low contrast PCI and the calcified lesion, which is what I do mostly in my practice. And some challenges here to consider are, when we use atherectomy or high-pressure balloon inflations, we often want to take a puff to make sure that there's no perforation or no vessel injury that we're concerned about. And that you just can't do when you're dealing with creatinines of 3, 4, and 5. Also, the increased complexity, length, and risk of the procedure can be challenging with minimal dye, but it's important to use the dye whenever you think that's going to help keep the patient safe. So some key things to consider is the IVL is a game changer for low contrast PCI. You use an imaging catheter to mark the treatment area like I mentioned, and imaging can really help reduce the number of pictures you need, help place your stent, but take the final angiogram at the end to rule out perforations. This is a case that was referred for a diagonal PCI. You can see here, this is my low contrast angiogram, 1.5 cc's of the right, 2 cc injection of the left. And here we see that the diagonal is actually CTO'd. So initially it was a 70% lesion. And so we thought, well, this is likely not causing this patient's recurrent heart failure exacerbation. So we IFR'd the LAD, which was 0.63, and decided to go ahead and proceed because we had only used 7 cc's of dye so far. Here you can see on IVIS that there are areas of 360 degrees of calcium, but they're not matching any of the other parts of the calcium score. And so because there was only one area of 360 degrees of calcium, we knew that the calcium score was 1. I went ahead and marked my distal landing zone with IVIS, didn't use any dye, dilated the lesion, placed the stent, post-dilated, and then you can see here our final IVIS with the good MSA and a good final angiogram. The last case is a similar one, again, low contrast angiogram of 7 cc's. You can see severely calcified vessels here. This patient had a GFR of 13 and was referred for complete revascularization for severe angina prior to renal transplant. We wired using a road map and were able to complete this case with about 3 cc's of dye. But what's important to note here is that on IVIS, the calcium score was 3, even though in the LAD, the calcium didn't look as bad as it did in the RCA. So based on that calcium score, we went ahead and took our shockwave balloon, ballooned with 40 pulses, and then dilated with the 3015 NC, and then you can see, again, very good calcium fracture and good stent expansion in this view here. 2 weeks later, I brought this patient back for RCA PCI. Looking at this, I thought I was going to do rotational atherectomy of the RCA, but I was able to get an IVIS catheter across and calculated the score to be only 1. And so in this patient, I went ahead and just used a non-compliant balloon and stented the vessel and got a good result here as well. And so what my main take-home points for you today are aggressive use of imaging at each step can help avoid stent underexpansion. It can also help avoid using atherectomy and IVL when you may not need it and help reduce costs for your institution. Second, the calcium score is very important to help determine calcium modification. Third, it's important to image before stent deployment to ensure calcium fracture. And fourth, consider the use of IVL, especially when you're trying to minimize dye in patients with CKD, which is often quite prevalent in patients with a lot of calcium. Thank you.
Great talk, Megha. So obviously, like you use a lot of IVIS, and I just my question for a lot of hospitals, more hospitals will allow you to have one device, like for imaging. So which one, and how do you go about picking it? Which one would you advise your colleague who's calling you from rural area to which device should I get, OCT or IVIS?
That's a tough one. I would say get both. But I think IVIS, I think OCT gives you a lot more information if you're a new operator, and the AI that's available now can really help not need you to train your eye as much. And so if you're not going to get the training, then OCT definitely has some advantages there because the software does a lot of the work for you and it's a lot easier to troubleshoot. But I think the advantages of IVIS, if you can take the time to train your eye in it and train yourself to use it, are that you can start to work with these minimal contrast patients. And so given that that's most of what I do, I find that the IVIS can be helpful for that. But I think if there was one device, I would say probably OCT, just because you can get a lot more information in one go with that.
Any questions from the panel or comments? Louis and Stefan after.
Great talk. It was alluded to earlier. Conceptually, it makes sense that calcium fracture would predict better stent expansion, but do we have any data to support that calcium fracture better predict stent expansion versus the old-timey dog bone before expands nicely with a reasonable pressure balloon after?
Not comparative data, but we do have some data coming out of CRF that's going to look at more of the calcium fracture, and some of that is in the studies that I showed before, but not head-to-head, no.
Rotaxis actually kind of rotablation Taxus stent versus usual Taxus stent, and the outcome was not as good, but nothing good with Taxus stent, and I think we're looking for the Eclipse to kind of inform us more. Stefan?
Nice presentation, Megha. When you do your score, you get over 2, then it's just telling you that it's a predictor of under-expansion in the studies, right? It doesn't tell you necessarily that a balloon would not work, right? So my question is that, do you religiously follow this as sort of a guide to say, I got more than 2, I gear up, I do IVL, or sometimes you go crazy and use a balloon sometimes?
So I've become famous in the lab for most of my patients are CKD patients with significant calcium, but I've sort of driven everyone crazy with I always take the NC balloon and try and get that to work. Maybe it's because I'm too cheap to pull out the atherectomy or too impatient, but I find that it often works. So my use of atherectomy is actually not very high, despite the fact that every single one of my patients has long-standing kidney disease. And the reason for that, I think, is because of aggressive use of imaging and because I'm confident once I've used that NC balloon and I have calcium fracture, then I don't need to go to it. Now, if I don't have calcium fracture, then I'll pull for the IVL. And sort of guide the therapy, and then it's not too often. Rota and CSI I'm using more in sort of those diffuse lesions where I'm seeing on IVUS that I have so many areas I don't think I'm going to have enough pulses.
I think, Yader, do you have a question?
Yes, just a very quick comment that I'll be interested in the panel's thoughts is, I think that going from choosing one device, as Cal was suggesting that we have to negotiate with administrators, I think we're moving to the need for 3 devices. Thinking about the next session on ACS and MINOCA, I think it's hard to say anything with the eagle eye, and more I think it's complementary, the use of both either HD IVUS or OCT. So I'll be interested in the thoughts of the panel, but I think we actually need the 3 devices in contemporary practice.
Well, and I think especially in 2020 where you may find out one day in your lab that you don't have any catheters of something because it's stuck on a boat and in the sea. That's happened to all of us in our labs where we've had to troubleshoot and use devices that maybe we don't use as frequently. One of the things, though, that I thought was really interesting on your presentation is you showed that case of the right coronary artery, and there was a dog bone, you couldn't expand it, and then you did the OCT. I think a lot of people would look at a lesion like that and they'd say, well, that's a small vessel. That looks like a 2.5 vessel. And, well, I'll try a 2.5 shockwave, and then they put it across and it looks like it expands, and then they start putting in stents. I think the important thing is that the OCT not only showed you that calcium nodule and where you needed to focally hit it, but it told you what size to use. You used a 3.5, and when you showed that you were using a 3.5 on that lesion, I thought, wow, that's much bigger than I would have predicted based on the angiogram alone. And I think that's what imaging tells you, is it tells you the size of the vessel, what device to use, and importantly, if you are going to use an NC balloon, you use the right size first.
It reminds me of, what Duane said earlier, that he doesn't image after treating, he goes with the stent. I do totally the opposite. So if I go with rota first and my rota's crossed and then I will balloon it, balloon expands, I think it's more important to image at that time than imaging before. I think if there's one moment of imaging is immediately prior to your stent implantation, because that's when the trouble will come. So you want to assess those fractures. You want to assess that you've done the right job. No matter what you're doing before is okay. But at this point, just check if whatever you've done is okay. I think it's important.
So I think I'll arm wrestle Stefan later, but I'm I'm sympathetic to everybody that's very, cost sensitive. I'm a cath lab director. I have to deal with the supply chain, et cetera, micromanagement of economics. But I'm sympathetic to everybody that wants to save the hospital a lot of money. It's not your money, by the way. It's their money. They're not losing money on cardiology. It's our job to show up to the meetings and explain to them about the medicine and to understand the finances of why it's advantageous to do things and what is the difference between OCT and IVUS and perhaps why we as clinicians think there might be a need for both in a cath lab or what. But let's not fall into the trap of trying to save a few $100 for the hospital administrators. I'm married to a hospital administrator. I try to save a few $100, but that's in our personal finances.
You don't even have a suit. Come on, man.
Yeah. Well, I let them pay for my clothes and do my laundry. But in the end, let's not fall into the trap of trying to save them money. Let's do the right thing and then make the economic explanations for why doing the right thing is better for patients and better for the hospital in general.
Honestly, I think if my hospital administrator will tell me you can have this device, and if I know clinically it's important for my patient, I will send my patient to the next hospital that have this device. We need, as a cardiologist, interventional cardiologist, to quit caving for administration and economic pressures because they all making money. Believe me, I know that. So we need really to defend our patient and our right to treat our patient
and
correctly.
Just be responsible about pulling off the shoe and pulling a Khrushchev and saying this is a patient care issue. Don't use it for every thing. But when you believe it's an important thing and you need to have something to do a good job, that is going to be a differentiator, and that's why all of you are at the top of your game, and that's why your cath labs will be able to compete effectively.
Great, thanks, Duane. Thanks, Cal, and to the rest of the panel. We're going to wrap up our session. We're going to take a quick break, and then at 10:30, we're going to be back here talking about acute coronary syndromes.